Happiness is not something ready made, it comes from your own action. So, we'll begin with a simple thought which is given by Dalai Lama. Today, we'll discuss the condition that is polyhydramnios. Polyhydramnios is a condition characterized by an excessive accumulation of amniotic fluid in the amniotic sac during pregnancy. It is important for nurses to understand the implication, causes, and management strategies associated with this condition to provide an optimal care for both the mother as well as the fetus. Polyhydramniosis is one of the recurrent cases which you can usually notice in the clinical area, and you come across these cases most often, and you should be able to manage the patient with this polyhydramniosis, giving a proper nursing care. First, we'll see the definition of polyhydramniosis. Anatomically, the polyhydramnios is defined as a state where liquor amni exceeds 2000 ml. That is, the amniotic fluid which is present in the amniotic sac will be more than 2000 ml. It exceeds 2000 ml. That's the simple definition of polyhydramnios. Incidence. The incidence varies from 5 to 1%, that is 0.5 to 1% of cases. It is more common in multipara than primigravida. So you can see that most commonly it is seen in multipara comparatively with the primigravida. So this is the statistics or the incidence in relation to polyhydramnios. Moving on to the etiology. The etiology of polyhydramnios, it may be the result of deficient absorption as well as an excessive production of liquor amni, which may be temporary or permanent. While certain maternal or fetal factors are found to be associated with hydramnios, yet the causes remain unknown in about 50% of the cases. But we can see that the composition of the liquor amni, however, remains the same. Let's discuss in detail the etiological causes of polyhydramnios. So the first cause stands here is fetal anomalies. Congenital fetal malformation is associated with polyhydramnios in about 20% of the cases. So there are certain listed down congenital malformation which may be the reason for polyhydramnios. In that, the first one is anencephaly. Hydramnios is found in association with anencephaly in about 50% of the cases. The causes of excessive production of liquor amni may be due to the transudation from the exposed meninges, absence of fetal swallowing reflex, possible suppression of fetal antidiuretic hormone leading to the excessive urination. So these may be the causes for increased amniotic fluid. So the absence of fetal swallowing reflex as well as the possible suppression of fetal antidiuretic hormone leading to excessive urination. So of course this shows that there is an increased amount of amniotic fluid. And the second cause stands is open spina bifida, increased transudation from the meninges. The third one is esophageal or duodenal atresia, preventing swallowing of the liquor. However, hydramnios is associated only in about 15% of cases of esophageal atresia. Next one, facial clefts and neck masses by interfering with the normal swallowing. The next one is hydrops fetalis due to rhesus isoimmunization, cardiothoracic anomalies, and fetal cirrhosis are often associated with hydramnios. So these are certain listed down things which comes under fetal anomaly, that is anencephaly, open spina bifida, esophageal or duodenal atresia, facial clefts and neck masses, hydrops fetalis. So these are the causes which you can see as open spina bifida, esophageal or duodenal atresia, facial clefts and neck masses, hydrops fetalis due to rhesus isoimmunization, cardiothoracic anomalies, and fetal cirrhosis are often associated with this hydramnios. The second cause is placenta. The placenta, because of chorioangioma of the placenta, that is, tumor growing from a single villus consisting of hyperplasia of blood vessels and connective tissues, result in increased transudation. Placental chorioangioma is the most common benign non-trophoblastic tumor of the placenta. And if you want to speak about hyperplasia, hyperplasia is an increased cell production in a normal tissue or organ. The third cause is multiple pregnancy. Multiple pregnancy is about 10 times more common than its overall incidence. Hydramnios is more common in uniovular twins, usually affecting the second sac. Fourth one is maternal. In maternal, diabetes. It is more common in hydramnios. Hydramnios is associated with diabetes in about 30% of the cases. However, with adequate supervision, the incidence of hydramnios can be lowered. It is presumed that a raised maternal blood sugar leads to raised fetal blood sugar, which is leading to fetal diuresis and of course to hydramnios. The other one is cardiac or renal disease. May lead to edema of the placenta. May lead to edema of the placenta, leading to increase in transudation, which of course leads to hydramnios. Moving on to the clinical types, we'll see what are the types of polyhydramnios. It is divided into two types as chronic and acute. Chronic is said to be one of the commonest type and acute is said to be extremely rare. Chronic, the onset is insidious, taking few weeks. So of course you know what is chronic, it's gradual. So here the onset is insidious, it takes few weeks. Whereas in acute, the onset is sudden within few days or may appear acutely on pre-existing chronic variety also. So these are the two types which has been said under hydramnios, that is chronic and acute. First we will discuss the first type, that is chronic polyhydramnios. So as I've said you, it is one of the commonest condition comparatively to the acute polyhydramnios. So chronic polyhydramnios, in the majority of the cases, the accumulation of liquor is gradual and as such the patient is not very much inconvenienced here. The symptoms which you can see is respiratory. The patient may suffer from dyspnea or even remain in the sitting position for easier breathing. Palpitation, and also you can see edema of the legs, varicosities in the legs or vulva and hemorrhoids. Signs, the patient may be in dyspneic state in the lying down position, evidence of preeclampsia, which includes, always when we speak about preeclampsia, it includes three symptoms, that is edema, hypertension and proteinuria may be present. So these are the symptoms as well as the signs of chronic polyhydramnios. Abdominal examination. In inspection, you can see that the abdomen is markedly enlarged, looks globular with fullness at the flanks. The skin is tense, shiny with large stria. So it's like fully filled with fluid, like the amount of amniotic fluid is more. So abdomen looks, of course it's very enlarged and it looks like a globe with fullness at the flank. Because of the increased amount of amniotic fluid, the skin is tensed and shiny. That's regarding the inspection. Moving on to palpation. In palpation, the height of uterus is more than the period of amenorrhea because you have an excess amniotic fluid here, and the girth of abdomen around the umbilicus is more than normal. Fluid thrill can be elicited in all direction over the uterus. fetal parts cannot be well defined, so also the presentation or the position. External ballotment can be elicited more easily. So the ballotment you can do because there is a lots of fluid inside, so it is very easy to do. But fetal parts cannot be well defined inside this uh, large amount of amniotic fluid. Fluid thrill. So what is fluid thrill? So fluid thrill, it is a test of it is a test to find the wave of the fluid. So here, if you want to test the fluid thrill, ask the patient or the assistant, whoever is with you, to press the edge of one hand vertically down the midline of the abdomen. So the assistant will be helping you to press the edge of one hand vertically down the midline of the abdomen. So you, what you're going to do is tap or flick one flank sharply with the fingertips while palm of the other hand is resting on the other flank. The positive finding is a thrill, which is better descriptor than a wave. Moving on to the auscultation. The fetal heart sound is not heard distinctly, although you can detect it or its presence can be picked up by the Doppler. Internal examination. The cervix is pulled up, may be partially taken up or at times dilated to admit a fingertip through which tense bulging membranes can be felt. Investigations. Sonography. Sonography is helpful to detect the abnormally large echo-free space between the fetus and the uterine wall. The single pool, so you have pockets where you're going to check the amniotic fluid index. The single pool will be more than 8 centimeter. Amniotic fluid index is more than 20 centimeter. In sonography, you are going to check the multiple fetuses, that is to exclude multiple fetuses, to note the lie and the presentation of the fetus, to diagnose any fetal congenital malformation. Next investigation is radiography. It's not commonly performed these days. The X-ray plate may be hazy at times. It may not be possible to exclude with certainty multiple pregnancy or bony congenital malformation of the fetus. Blood test. In blood test, you are going to do a ABO and RH grouping. Rhesus isoimmunization may cause hydrops fetalis and fetal ascites. Postprandial sugar and, if necessary, GTT, that is glucose tolerance test, which we call it as also oral glucose challenge test. Amniotic fluid. Estimation of alpha fetoprotein, which is markedly elevated in the presence of fetus with an open neural tube defect. So these are the certain investigations which has to be performed in order to investigate or rule out the polyhydramnios, that is sonography, radiography, which is not commonly done nowadays, the blood test and also the amniotic fluid test can be done. Moving on to the management. So what is the management of polyhydramnios? Fortunately, recently there has been a falling trend in the incidence of hydramnios of severe magnitude. The reason for this falling statistics in case of polyhydramnios, the early detection and control of diabetes, rhesus isoimmunization is now preventable. Genetic counseling in early months and detection of fetal congenital abnormalities with ultrasound and their termination reduce their number in late pregnancy. Minor degree hydramnios. It is commonly found in mid-trimester and usually requires no treatment except extra bed rest and rest for few days. The excess liquor is expected to be diminished as the pregnancy advances. Severe degree hydramnios. In a wave of risk which is involved and the high perinatal mortality rate involved in the severe degree hydramnios, the patient should be shifted to a hospital which is equipped to deal with the high risk patient. So usually in the hospital they have a separate unit where the high risk patients are monitored. So usually the patient with the severe degree of hydramnios will be admitted to an area that is high risk unit. So this patient has to be monitored in high risk unit to prevent the complications of hydramnios. Principles of management. So when you're going to manage any of the case, the principle is one of the heading or one of the concepts which has to be kept in mind always. So what are the principle which you have to keep in mind when you're dealing with the case of hydramnios? The first thing is to relieve the symptoms, to find out the cause, and the third one is to avoid and deal with complications. So these are the three main principles which has to be kept in mind. Supportive therapy. So in case of supportive therapy, the main thing is bed rest. It includes bed rest if necessary with backrest, analgesics and sedative as and when required, and treatment of the associated condition has to be dealt, like preeclampsia, diabetes. The use of diuretics is of little value here. Indomethacin given orally to the mother, that is 25 mg every 6 hourly, has been found to decrease the amniotic fluid. The investigations are done to exclude the congenital fetal malformation. Further management depends on the response to the treatment, period of gestation, and also the presence of fetal malformation. Based on this identification, the further management goes. In uncomplicated cases, how to deal with the uncomplicated cases? So what do you mean by uncomplicated cases? In when we are speaking about the uncomplicated cases, means there is no demonstrable fetal malformation, so it doesn't include any fetal malformation. Response to the treatment is good. So in such cases, the pregnancy is to be continued, awaiting for the spontaneous delivery at term. So as I've said you, if the response for the treatment is good, of course you can wait, and you can make a lady to wait till the term and wait for a spontaneous delivery. If the patient is not responding for the treatment, that is unresponsive. So unresponsive, that may lead to a maternal distress. If it is that case, so pregnancy which is less than 37 weeks, what you're going to do, and the pregnancy more than 37 weeks. If the pregnancy is less than 37 weeks, an attempt is made to relieve the distress with the hope of continuation of pregnancy by amniocentesis. Here, slow decompression is done at the rate of about 500 ml per hour, and the amount of fluid to be removed should be sufficient enough to remove the mechanical distress. Ordinarily, it should not exceed 1 to 1.5 liter. Because of slow decompression, the chance of accidental hemorrhage is less, but liquor amni may again accumulate sooner or later, for which the procedure may have to be repeated. Pregnancy more than 37 weeks, what you are going to do? Induction of labor should be done. The following procedure may be helpful. The amniocentesis, that is drainage of good amount of liquor amni to check the favorable lie and presentation of the fetus. A stabilizing oxytocin infusion can be started. You can go for a low rupture of the membrane is done when the lie becomes stable and the presenting part gets fixed to the pelvis. This will minimize the sudden decompression with separation of the placenta, change in the lie of fetus, and cord prolapse. High rupture of membrane with Drew Smith catheter may lead to accidental low rupture of the membrane and escape of gush of liquor amni with its incidental hazards. If the case is with congenital fetal anomaly, what's the management? Termination of pregnancy is to be done irrespective of duration of pregnancy. The patient is relieved of symptoms, and unnecessary development of pregnancy complications are also avoided. Amniocentesis is done to drain a good amount of liquor amni. Thereafter, induction by vaginal PGE2 gel insertion followed by a low rupture of membrane is done. During labor, the internal examination should be done. During labor, the internal examination should be done soon after the rupture of membrane. The reason is to exclude the cord prolapse. It is one of the obstetrical emergency. If the uterine contraction becomes sluggish, then of course you have to start with oxytocin infusion is started if it is not contraindicated. That also has to be kept in mind. To prevent postpartum hemorrhage, intravenous methogen 0.2 mg should be given with the delivery of the anterior shoulder. But nowadays the methogen is not given. The trend is now we are giving injection oxytocin, that is 10 units IM will be given, that is the one instead of methogen. The reason is the methogen will shoot up the blood pressure. In olden days, of course, we used to give injection methogen, um, but before giving methogen, it is essential that you have to check the blood pressure of the patient, because if the patient the patient blood pressure is high and again you are going to inject methogen, of course it will shoot up the blood pressure. So now we are giving injection oxytocin 10 units IM. And other thing is, one must remain vigilant following the birth of the baby for retained placenta, postpartum hemorrhage and shock. And regarding the baby, you have to see for esophageal atresia of the baby should be excluded by inserting a rubber catheter, that is you can insert the Riles tube down to the stomach to find out whether there is any esophageal atresia. Moving on to the next type, that is acute polyhydramnios. The onset is acute and the fluid accumulates within a few days. It usually occurs before 20 weeks of pregnancy. As we have already said that the acute polyhydramnios is rare compared to the chronic polyhydramnios. The symptoms which can be noted in acute polyhydramnios is abdominal pain, that is acute abdominal pain, nausea and vomiting. These are the symptoms which can be noted in case of acute poly. Signs: the patient looks ill, absence of features of shock, edema of the legs or presence of other associated features of preeclampsia, abdomen is hugely enlarged more than the period of amenorrhea, fluid thrill is present, fetal parts cannot be felt nor is the fetal heart sound audible. Internal examination reveals taking up of the cervix or even dilatation of the os through which the bulge membranes are felt. Sonography shows multiple fetuses or at times fetal abnormalities with radiography. Often the plates become too hazy to interpret. Differential diagnoses include accidental hemorrhage, retroverted gravid uterus and hydatidity-form mole. So when you are diagnosing the case of acute polyhydramniosis, you also have to see for the accidental hemorrhage, retroverted gravid uterus and hydatidity-form mole. The treatment: most often the spontaneous abortion occurs. To relieve the distress which is caused by this polyhydramnios, decompression has to be done. On rare occasion where the baby is specially valuable, repeated abdominal amniocentesis may have to be done in an attempt to continue the pregnancy. So this is the treatment for acute polyhydramniosis. So today we have discussed about the polyhydramnios. We have seen the introduction, the definition, the incidence, the etiology, the etiological factors like fetal anomalies, placenta, multiple pregnancy and maternal factors which include diabetes, cardiac or renal disease. And we have seen the main two clinical types, that is chronic polyhydramnios and acute polyhydramnios. Under chronic polyhydramniosis, we have seen about the signs, the symptoms, what are the related to the abdominal examination, what you are going to do in inspection, palpation, auscultation, internal examination, what are the investigations you have to do, and what's the management of chronic polyhydramniosis. And later we have seen about the acute polyhydramniosis. In this also the signs, the symptoms, the differential diagnosis, and the treatment of polyhydramniosis. So that's regarding the polyhydramniosis. So by understanding polyhydramniosis, the nurses can play a critical role in the early detection, monitoring, and management of this condition, thereby improving the outcomes for both the mother and the fetus. I hope you have got an idea, some idea of the polyhydramniosis, its types, the and signs and symptoms, and its management. If you have any questions based on this, you can please put it down in the comment section. Thank you.